Hey, good afternoon, everybody. My name's Kyle Rooney. I'm as of this month, past president of the Angelman Syndrome Foundation Board. So thanks, Michael. Appreciate that. Um, I have the privilege of introducing Amanda Tourget, nurse practitioner at Mass General. She plays a central role in the ASF specialty clinic at Mass General. And I know when I was looking at the agenda, this was one of the topics that I circled and I was excited to learn more about. I wish in some way being the past board president helped me with this subject with my son, Madden 11, who struggles with sleep. And I know many of you and your loved ones do as well. And that just exacerbates all issues. So I'm really looking forward to what Amanda has to share. And we're excited to have you. Thank you.
Hi guys. Um, Happy to be here. So I'm just going to talk about, well, sleep and Angelman syndrome. So just a show of hands, how many of you are experiencing a lack of sleep right now? All right. All right. We'll talk about that. Hopefully we can maybe fix a little bit of it. So first I'm going to talk about why sleep's important. And then I'm going to talk about some common sleep issues. And then we'll talk about managing those sleep problems. So how can the sleep kind of present? It can complicate medical comorbidities. So oftentimes it can exacerbate seizures. Kids can have headaches, muscle aches, all sorts of issues associated with the lack of sleep. It can cause daytime fatigue and tiredness, which then leads to behavioral difficulties. So it can cause increased impulsiveness, anger, irritability, and then it can also cause cognitive difficulties. So when we sleep, that's when we commit what we have learned throughout the day to memory, and we just secure those memories. So, working memory is responsible for some of our executive function. So if we're not committing those things to memory, it causes difficulties with learning. You can't pay attention as well, and you're not able to focus. It can also cause physical distress and slow down physical development. This goes kind of with the cognitive part of things. And then it slows down academic progress. It's difficult to pay attention when you're too tired. So the two things that kind of help us sleep, one's circadian rhythm. So circadian rhythm is basically, it's brought on by night-day rhythms. So what happens is, at night, it gets dark. We're not in the lighted environment. The neurotransmitter melatonin is released from the hypothalamus, and that helps us be sleepy. The other thing is homeostatically regulated pressure to sleep, which is basically driven by how much you're awake. If you're awake for long periods of time, then your pressure to sleep is strong and you become tired, and that helps us sleep. So things that I usually do when somebody comes into clinic to see me for sleep is the first thing I'm going to do is rule out medical complications. So first things first, I work with Dr. Thiebert. So seizures, we want to get those under control if that's an issue. Second, oftentimes reflux and constipation kind of go hand in hand with these kiddos. If it can't go out, it must come up, right? And so sometimes we'll see kiddos have difficulty with sleep due to reflux. What'll happen here is they'll lay flat, the acid kind of comes up, causes irritation, and they wake up. And this might happen 2 to 3 hours after they've gone to bed, and this can go on throughout the night. So they'll wake up, they're usually irritable when they wake up because they're in pain, and then they go back to sleep, and then a couple hours later, they wake up again. So oftentimes we'll look at constipation and reflux. I know someone had mentioned before me dental problems. These kind of go unnoticed a lot of times. So we'll make sure that they're not experiencing any pain in their mouth. Some kids will have headache. Then we talk about sleep schedule, and then last but certainly not least, medications. So other medical considerations would be sleep apnea. So if kids can't breathe well at night, obviously they're not sleeping well. I'll look at lab values. So sometimes kids will have low iron that can lead to restless leg type movements in their sleep. So sometimes we'll look at that, or other lab values. Kids on the diet can have low CO2, those kind of things. Again, reflux, constipation. Parents always ask me regarding sleep apnea, or when their kids have sleep problems, whether they should get a sleep study. I don't do sleep studies very often for a number of reasons. Here's a picture of a kid with a sleep study. It's often hard on parents and even harder on the child. We don't get accurate picture because it's hard to sleep when you're hooked up to all of these things and get an accurate picture for these kiddos. It often induces a lot of anxiety. So the times when I will get a sleep study are typically if they're snoring, and I think that there might be sleep apnea, or sometimes if we just really can't figure out what's going on with sleep after sleep schedule and medications. So some of the problems that we see, we'll move on to sleep problems, are bedtime resistance. So refusal to go to bed, persistent calling out or getting out of bed, if it takes them a long time to get into bed, and then frequent nighttime appearance, awakenings, or needing your parents to sleep with you. Most of the time, I'll start with sleep schedule, and a lot of these problems can be helped with sleep schedule. So the first thing to establishing a sleep schedule is determining the appropriate time in bed for your child. And so I have put this little schedule to get based on age and, the maximum time in bed, the minimum time in bed. What I hear a lot is parents think that because their children have Angelman syndrome, that they may need more time in bed or more sleep. That's not necessarily true. We do, of course, want to make accommodations for kiddos that have seizures, and those will make them tired, or make accommodations for those things that are going to cause them to be more fatigued throughout the day. However, determining an appropriate time in bed for your child and sticking to that is one of the first steps to a good sleep schedule. Once we've done that, we're going to consolidate the sleep schedule to make the pressure to sleep stronger. So when you make the pressure to sleep stronger and consolidate the sleep schedule, that helps. You're going to crunch that little sleep schedule. It helps them fall asleep a lot easier, and it helps them stay in bed longer and decreases nighttime wakenings. The reason behind this is we all have lighter periods of sleep and we all have deeper periods of sleep. During those lighter periods of sleep, if our pressure to sleep is not strong enough, kids will often wake up and want to party. So when we consolidate that sleep schedule and make that pressure to sleep strong enough, that'll help them stay asleep during those lighter periods of sleep. So we want to establish that consistent sleep schedule throughout the week. So 7 days per week, we want to set a bedtime that works for them to go to bed with a consistent bedtime routine. And then we want to establish that wake up time. And the consistency is very important because we all want to sleep in on the weekends. I get that. But sometimes kiddos will be getting up at, say, 7 a.m. during the week. They're getting up. And then on the weekends, if they're sleeping till like 10 on Saturday and Sunday, then when it comes Sunday night, their pressure to sleep's not strong enough. So they want to stay up later. Then they can't fall asleep. And then they're tired in the morning on Monday. And that causes the whole, the schedule to be off for the rest of the week. So just establishing that consistency is very important. And then a consistent bedtime routine. So this is important because most children love consistency, but also you can kind of establish a routine. And if there's bedtime refusal or not wanting to go to bed, oftentimes I'll tell parents to pick a few key items they like to do, like most kids or angels like bath time. So I always say, get them to do the things they don't like to do before they do the things that they do like to do, and make that their routine every night. So they know, if I do these, then I get to do this. And that makes it a little less traumatic for them. So sleep practices, and these are all recommendations. And I understand that a lot of times it's easier said than done, right? So putting your kid to bed drowsy but awake, oftentimes this can help with kids who have that separation anxiety. So they will, so kiddos remember when you put them to bed, they'll remember, oh, mom was in here when I went to bed. So if they're asleep already, oftentimes when they wake up, they'll reach out and call for whoever it is that put them to sleep. But if they're kind of drowsy instead of being asleep, then they do that a little less. I do find, I don't have a child with Angelman syndrome, but I do have a 2-year-old, and putting her to bed drowsy but awake is a definite no-go. So a way around this, I guess, is really consolidating her sleep schedule to make sure that she doesn't have those nighttime awakening, so she's not waking up and crying out for anybody. And then something to do is let the child cry just a little bit longer before responding. Other sleep practices would be sleep environment. So you want cool, dark, quiet. We all know that. But safety is probably the most important. And I think I talk about this a little bit later on, but some kids might need a covered bed or a mattress on the floor. I have had parents take everything out of the room that can be ripped off the walls or climbed, and just make basically one big room where they can sleep. I always tell parents, as long as they're sleeping, that's good. Even if they fall asleep outside of their bed, that's okay. They'll eventually kind of figure it out. And then the bedtime routine. So this should be 20 to 45 minutes. Like I talked about, you're going to put the more preferred items last, the less preferred items first. Should be specific and predictable. So something that they come to expect every day, and consistent every night. So interventions, when the sleep schedule and consolidating that sleep schedule doesn't work, then we kind of move on to other interventions. So the first one I usually will suggest is cry it out. That's not for everybody, and that's okay. I thought when I had my daughter, I had, a lot of visions of how things were going to go. And then there was the reality of how things actually went. So when it came to letting her cry it out, that was, not for me. If they don't want to cry it out, or if that doesn't work, then we do checking in. And how this works is we'll have mom or dad put the child to bed, and then they're going to check in with them every 5 minutes. You're going to check in with them until they fall asleep. So the important part is that you return to their bed and make sure you're checking in, because like I just talked about, the last person that they remember is going to be you if you're in there with them when they fall asleep. So the idea is that you're out of the room when they fall asleep. So sometimes, parents will be like, oh, I forgot to switch out the laundry. I'll be back. And they leave and they come back. Or, I forgot to brush my teeth, and they leave and they come back. And you keep doing that, leaving and coming back until they fall asleep without you in the room. And then the last one that we use, this one's kind of extreme, and can take a little bit longer, but graduated extinction. So this is, you set a chair by the bed and gradually move that outside the room. So farther and farther away from the bed, move it every 2 to 3 nights. As they get comfortable with it, you move the bed again, or the chair. Some parents will put like a twin size bed on the mattress on the floor, and they can just move that outside the room. So common sleep conundrums. So the crib to bed transition, like I talked about a minute ago, some kids will need sleep safe beds, or parents will just basically turn their room into a giant crib. They'll remove everything from the room. Gates are really handy in this instance. Sometimes I've had parents stack 2 gates so that the kiddo can't escape the room. I have had parents who have locked the door. I'm not promoting that, but sometimes that's the safest. You just want to make sure that, you have a good plan in place if there was an emergency, such as a fire or something. And then the other issue is naps. Usually kids get rid of their nap between 3 to 4 years of age. I do find some kids will fall asleep in the car or on the bus on the way home from school. So usually, any daytime sleep, we try to eliminate that to help with that pressure to sleep. So sometimes that might be having the bus monitor make sure they're not falling asleep, or, blasting the radio really loud in the car. But that nap, transitioning from nap to no nap, can be very difficult sometimes. Nighttime feedings is less common. I see in Angels, but some kids do wake up to feed, or they want food in the middle of the night. So oftentimes I'll tell parents cold turkey, because between 4 to 6 months of age, you can usually sleep through the night without eating. So, the older kiddos should be fine without that midnight snack. Pacifier use. This is one of those situations where I myself realized it was a lot easier said than done. I usually say eliminate the pacifier. During those lighter periods of sleep, kiddos can wake up and they'll search for the pacifier on the bed. So I'll hear parents say we have 4 or 5 pacifiers in the bed, but even though they have many pacifiers, they're still waking up to look for them. There are many ways you can get rid of the pacifier use. Some parents want to send it to the Binky Fairy, and some go cold turkey. I found the countdown pacifiers very helpful, actually. I was like, we're going to do this cold turkey. So I actually made my daughter throw her Binky away in front of us. And that was until she got herself so worked up that she cried herself into vomiting. And so it was the countdown pacifiers that got us there. And those are just pacifiers that get smaller as you go. You can kind of trade them out as they become used to them. And then electronics. So where this kind of comes in is the circadian rhythm. So circadian rhythm can really get thrown off by electronics. The blue light from that can throw off your sleep schedule and make it difficult to fall asleep. I know this is very difficult because sometimes when kids are up in the middle of the night and you really need that sleep, you want to give them the iPad to watch for a little while. So I always tell parents, if this is a survival mechanism for you, turn on the red light to help with the blue light to keep on the device so that that's not keeping them awake. And then medications. So I know they touched on this in when they were talking about seizures, but so I always tell parents every child is different. What we choose for one child might be different than another. We oftentimes will look at seizure medications and see how we can maximize those best to help with sleep before we start prescribing medications. But we have a few medications that are pretty common. So I've kind of listed the first few medications that we normally use. So melatonin, this is again a hormone neurotransmitter that's released by the hypothalamus. It mainly affects circadian rhythm. So if it's a pressure to sleep issue, the melatonin is probably not going to help. With melatonin, there was actually a study done that showed that it was actually done in Canada, but it showed that some of the melatonin, it's not FDA regulated, so some of the melatonin had other things in it, or some didn't have melatonin in it at all. So I also patients to make sure there's a label on the side of it that says it's FDA monitored. And what that means is that they just send a batch off every few months so that you know what's in it is what's actually in it. And that the melatonin mostly helps to decrease sleep onset latency. So it helps kids fall asleep. The other thing with melatonin is if they're having a circadian rhythm difficulty and you want them to go to bed at 8 o'clock, but they're going to bed at 10 o'clock, in order to kind of correct that, you're going to give the medication at 6 p.m. So you're going to give it 2 hours before if it's taking them 2 hours past when you want them to fall asleep. Clonidine, I usually use this to help fall asleep. It has a long half-life, but it doesn't usually help kiddos fall asleep because its mechanism of action reduces REM sleep and slow wave sleep. So it helps fall asleep. And then gabapentin and trazodone, both of those help kiddos stay asleep and fall asleep. Gabapentin can be helpful in a sense that it can help with anxiety too. So if they're very anxious around bedtime, you can give gabapentin and that'll help them stay asleep as well. And then trazodone is probably used the most. It can help improve sleep continuity. So it decreases those nighttime wakings. But I talk about medications cautiously because I think the most important part of it is the sleep schedule, because without, you have the two mechanisms, circadian rhythm, and then, your pressure to sleep for helping you sleep. So it's imperative to have a good sleep schedule. Otherwise, medications are just a Band-Aid to help your child sleep. And with that, I think I talked rather quickly. I tend to do that when I'm a little nervous. So does anybody have any questions?
Of the drugs that are listed, can you build a tolerance to these drugs and over time they just become less effective? My son's on trazodone. He does pretty well with it. But I've heard a lot of stories in the community that one day it just stops working. Does that happen? And then also with melatonin, is that become an issue?
So with melatonin, it's one of those things for me, melatonin either works or it doesn't work. And so melatonin is especially not going to work if it's not a circadian rhythm issue, if it's a sleep schedule issue. So, and I think that's kind of the issue with most of these. They don't necessarily wear out, but kids get older and need bigger doses. But also when kids get older, they need less time in bed. And so scrunching their sleep schedule usually helps with that the most. I've not had them just stop working or kids build a tolerance. Usually it is they're growing, they grow out the size of the dose, and their sleep schedule needs to be scrunched. So, which I get is difficult because when they get to that age, to almost teenagers, they only require about 8 to 9 hours of time in bed. And some of them, it's difficult to just let them relax and chill at night. And parents usually want that downtime. So sometimes that can be a difficult transition.
So my wife and I have gotten to the, like, we've done everything that we can for the sleep before we're trying like the prescription meds, and like now we're at that point. So you said like the clonidine, that one wouldn't help stay asleep, just like help fall asleep?
Yeah. So if you, so clonidine reduces your REM and your slow wave sleep. So it doesn't necessarily, even though it has a very long half-life, it doesn't help them stay asleep. It usually helps fall asleep. So if I have a kiddo that has frequent nighttime wakings, normally I will do gabapentin or trazodone. Trazodone, I use gabapentin typically for my very anxious kiddos, but trazodone is usually a good go-to.
Okay. So trazodone would be help, because she doesn't really have a problem like falling asleep. Like she can fall asleep really easily, but it's just that waking of the night.
Yeah. So
So
you want to first check out and make sure she's not having reflux or any
yeah, which
constipation,
we have done all that, and she's pretty,
and her sleep schedule's consolidated.
yeah, like we are on a tight schedule. This is the
And-
time that you do it and everything
and
like
got
that.
the room set up.
Yeah.
Blackout curtains. They were
Yep.
my savior a few weeks ago.
Yeah. So that's that trazodone would probably be the one to
Yeah.
speak to the neurologist. Okay. All right. Thank you.
My angel is 23 years old and we have a sleep schedule issue. So I was wondering what medicine, like, suppose he's gone off track. Like the one night he's not sleeping the whole night and the next day he sleeps. So he doesn't need more sleep. For him, 5 hours of sleep is good enough. And he's active and he's ready to go. So what medicine do you recommend that we should start to jumpstart a sleep schedule? For example, like he has a sleep schedule, but one day he went off, and then the whole next week he's completely off because the whole night he's awake. Day he tends to sleep. Even though we put music or whatever, if he has to sleep, he'll sleep sitting.
So there's
Doesn't
no
matter.
keeping him up. To
Yes. So
make that
is there
perfect sleep.
any medicine that we can give him to just to get him back
So
on
any of
track?
these will really work, but if it's an issue with him falling asleep, I would try clonidine first. It's easy. It helps with anxiety. It also has anti-anxiety properties too. So usually if I'm trying to get a kiddo on to a sleep schedule, I'll start with clonidine and try that.
Okay.
I do that even in kids without AS.
So what are the my next question is, if do they have any side effects of clonidine because he's already on medicines? I don't want to introduce some medicine that I have to again worry about what does clonidine has,
So if you look
how
clonidine
safe
up,
is.
if you look clonidine up, it's a blood pressure medication, but it's usually used at much higher doses than that. So it can help. So the biggest side effects are going to be sleepiness, which is what we're looking for, right? And it can help with anxiety, but most of the time, those are the two most common side effects that I have with that medication: sleepiness and anxiety,
Okay.
or lack of anxiety helps with anxiety.
Okay.
Sorry.
Anxiety. I was like, okay,
Yeah,
adding to
I
anxiety.
would never give something that causes anxiety. I'm sorry, I misspoke.
Okay. Thank you.
Anybody else? No? There you go. All right.
Thank you so much, Amanda. We appreciate it. Give her a hand. Thank you.